Hello, welcome to EPG Pathshala. The module that we would be discussing today is Ergonomics in Laparoscopy. Now, outlining the introduction for the whole topic, I would like to start with that again, laparoscopic growth is unprecedented. Laparoscopic cholecystectomy and other operations are something that is on the tips on each and every people in the society right now. But laparoscopy is a significant departure from an open surgery that we used to perform for the multiple centuries up till now. It has bring its own set of challenges. There is spaghetti of wires in the OT, multiple panels, a surgeon makes small incisions in the abdominal wall, there are long instruments and the movements are counterintuitive. Ergonomics in its entirety means suiting a worker with the worker environment. In this case, we are suiting the surgeon with the operation theatre, with the instrument, so that we could perform faster, easier and comfortably a surgical procedure, and in that sense helping the patients. So intuitively, studying ergonomics in laparoscopy is very essential and seems right. So starting with the first thing that we are going to talk about is what is the need of ergonomics in laparoscopy. As I just talked, it is a significant departure from an open surgery. The surgeon stands in an awkward procedure for multiple hours in a static position. There are also many musculoskeletal complaints, eye stress, mental stress that the surgeon has to put up with. He stands in an awkward procedure like this, in which the hands are abducted, and this is also known as chicken scapula, and the surgeon develops many of the times a laparoscopic soldier standing in this position. Also, in open surgeries, we used to use our hands. The upper limb of a human body has 30 degrees of freedom, whereas a standard laparoscopic instrument has only 4 degrees of freedom. That is in and out, rotation, up and down, and one more. So, with these limited degrees of freedom, it becomes very difficult for a surgeon to perform the similar surgery in laparoscopic mode. Also, if we are going to talk about the vision which is available on the panels, no matter how good it might be, it's still a two-dimensional vision. Secondly, there is no depth perception because it's not a 3D vision. Also, it's a circular vision. So there is loss of peripheral vision. We are not able to see whether our instrument is coming from the side or not, and we are not able to see other components of the abdomen. We are only targeted towards a single field. Also, many of the times in many operation theatres that we see, the panel is located somewhere else, whereas the direction in which the surgeon is operating is somewhere else. So there is disconcordance between the visual axis and the working axis. Also, open surgeries we used to use our hands. And in those instruments, we used to have a fulcrum effect where we can apply a lot of power. But in laparoscopic instrument, the grabbing arm is very small and located at the distal tip of the instrument, and the handles are located at the other end. So there is disconcordance between the power that we are applying and the power which is exhibited at the instrument other effect. Also, we used to say that hands are the eyes of a surgeon. So especially in these cases, that saying does not remain true. So in a field like surgery we are talking, where it is limited by the skills of the surgeon, the skills itself are limited by the introduction of laparoscopy. So the surgeon has to develop a different set of skills. Hence, the study of ergonomics becomes more reasonable. So starting with, the first thing that I would like to start is that how are we evaluating the current posture of a surgeon and other factors of ergonomics. So the first thing that we will start is with the surgeon's posture. Traditionally, it was on observational basis, that a person used to observe that how the surgeon is standing for how much period of time and whether it is comfortable or not. It was a very subjective test. But now in this era of all the instruments that we have 3D motion tracking cameras. Now in this same area only, we have new developmental things which are known as inertial markers. As we can see on the diagram, the surgeon is wearing a whole body suit with multiple inertial markers on her body, so that whenever she operates, a 3D real-time photograph, or we can say a real-time model of a surgeon is created in a computer, and we can see what is his posture and on what posture he is standing for a long time, and we can do the observational basis there also. Now another most important thing is to measure the stress on each and every muscles of the hand and other the muscular joints. For this we have various instruments. To start with, one of the things is called electrogoniometers. Now as we can see in the diagram, they are placed on the various aspects between the joints on the arms, on hands, arms and forearms, and whenever the joint is moved, they convert the movement on joint into the voltage. So that could be objectively measured. Also there are something which is called as data gloves. When we wear those gloves and then operate, so they can measure each and every pressure points and other movements of the hand. There is also electromyography, in which it can be identified that which groups of muscles are getting activated. Also there are some things which are known as force platforms. These are used as a basis on which the surgeon stands. So it can be measured that at what posture and how much energy he is putting into one posture, into his one leg, and how much time he is spending on the other leg. So those things can also be objectively measured. The next things are called as subjective tests. So the most important thing is known as Search TLX. Now this is something, a questionnaire type of thing, which is derived from NASA TLX. Like other things which have been derived from other branches of science, this questionnaire was derived from the NASA TLX, which used to collect data about the mental, physical, temporal demand, effort, performance and frustration. So it is a subjective test to know how the surgeons are coping up with this environment. Also, to gather information, there could be subjective questionnaires which could be made from case to case basis for study to study basis. Now the first thing in ergonomics, that what we should do to get a better coordination between the surgeon and the operation theatre is, we will start with operation theatre ergonomics. Now the most recent thing that has come into the operation theatre is known as modular OTs. Now in what happens in modular OTs is, all these instruments and instrument tables, panels and other things which could be ceiling mounted is ceiling mounted, so that it could be moved from one place to the other, the height could be adjusted and more space is available and better cleaning can ensue. There are other factors of modular OTs like laminar flow of air and all the corners are smooth, but in relation to ergonomics, ceiling mounted is one of the most important things. The second important thing is, what should be the adequate height of the operation theatre. The concept is that the instruments should lie at the elbow level of the surgeon, so that the hand is in relaxed position. For that, the operation theatre table height should be around 67 to 70 centimeters above the floor. But if the surgeon is very small and the operation table cannot go even below that, some platform should be used so that the surgeon could get some elevation. In the end, the hands should be in comfortable position. The another thing is known as straight line principle. This says that the surgeon and the working area and the panel at which the surgeon is looking, the screens that should be in straight line. This makes the movements more intuitive and the intuitive movements are better processed. Now another thing is known as the gaze down view. The panels earlier were located not in straight line principle, at some other place. Also they were located at a height. The consensus which has been reached upon is that the panel should lie approximately 25 degrees below the horizon, 4 to 8 feet away from the surgeon's eyes, so that it appears that surgeon is gradually gazing down upon the panel. So that should be the prescribed location of a panel. Another thing is known as coaxial view, but then again it matches with the straight line principle. That means your working axis of a surgeon with the laparoscopic instrument should be in line with the visual axis. It should not be that he is working in this axis and he is seeing into the panel into the different area. Wherever in such operations which are lengthy and which enrolls multiple times of changes of the positions of a surgeon, 2 or sometimes even more than 2 monitors should be available in the operation theatre. Other things are that foot pedals are something which are also used in laparoscopic surgeries for activation of electrosurgical instrument, that whenever the surgeon is operating and he need to coagulate or cauterize something, he needs to press a foot pedal. So foot pedals should also be located near the foot into the direction of surgery, and also there should be a resting area where the surgeon could rest his leg. Otherwise, during the course of surgery, he keeps looking for the foot pedal and it creates mental stress. Now the diagrams that are in front of us, I would like to show you the first diagram, that is showing the surgeon operating into the laparoscopic field and the panel is right in front of him. This is known as the coaxial view. The second diagram that you can see is of a modular OT, where you can see most of the panels and the C-arms, they are mounted from the ceiling so that they could be moved from a place to place, height could be adjusted, and the floor is all empty so that movement of instrument and trays could also take place there. The next thing that is very important and that needs to be talked about is the posture of the surgeon and his position. There are two famous laparoscopic positions of a surgeon. The one is the American, in which the surgeon stands in the side of the patient and he operates either from the left or the right side of the patient. The second is called the European system, in which the legs of the patients are opened and the surgeon stands in between him. None of the position has been seen to be superior than other in any of the control trials, and both are equally accepted. The another thing is what should be the position of an arm during surgery, of a laparoscopic surgery. The surgeon should have arms slightly abducted, retroverted and inwardly rotated. This has been seen as the most comfortable position for the surgeon, and the angle which should be there at the elbow should be around 90 to 120 degrees. The basic concept is that the surgeon should have a straight head, relaxed shoulders, non-rotation of spine, forearm in slightly descending plane with hands lightly gripping the instrument. This is the most comfortable position of the hand, and we will be talking this in the coming slides. Now here is a diagram where we are showing the same principles that we talked about in the last slide, that the surgeon is standing comfortably with the straight spine, straight head, with the angle at elbow of 90 to 120 degrees, forearm is slightly descending plane, and the foot pedal is near the surgeon's feet into the straight line. Now the second one of the most important things, and multiple studies has been done on it, are the trocar placements. Generally for surgeries like laparoscopic cholecystectomy, 3 to 4 trocars are used, but for more surgeries, more complicated surgeries, bariatric procedures, multiple up to 5 to 6 trocars are also used. So what is the final placement of a trocar? That is dictated completely by the surgeon preference, that how he needs and where he needs those trocars for. There is no doubt about it, but still there are some guidelines which should be followed and which gives a better ergonomic response. One of the first thing is known as the triangulation concept. It says that the camera and the working ports should form an equilateral triangle. The second is called the baseball diamond concept. Now that says this equilateral triangle that we talked about, of the camera in between and the working trocars making an equilateral triangle, should all face towards the panel that we are operating from. It's like the second base, the third base, and the home run is our panel. Now the second thing is the instrument should not be very closely placed, because if they are very closely placed and the movements are all counterintuitive, so it seems like the two swords are cutting each other. Like it's also known as dueling of swords, like the swordsmen used to play with each other's swords. The third thing is known as sectorization. Now this is a departure from the normal used concepts, in which the camera port, instead of being placed in the middle and the working ports placed in the side by side, the camera port is placed at one side and the working ports are placed at other sides. Now this is done in some surgeries like laparoscopic appendicectomies. Now here is a diagram where we are showing the baseball diamond concept. The surgeon with the camera is standing at the home plate. The second and the third base is occupied by the working trocars. The surgeon is standing here, and all again this equilateral triangle directs towards the panel, and this which is like the home run of the baseball court. Now talking about the instrument angles, this is also very important. Again I would like to repeat that the final preference is dictated by the surgeon preference, whereas still some ideal angles have been described which are ergonomically very helpful to the surgeon. The first thing is the manipulation angle. So if the surgeon is like this and operating with the instrument, there should be an angle between those two instruments, and ideally it has been seen that if this angle remains around 60 degrees, there is a range definitely between 45 degrees to 70 degrees, but if it remains approximately 60 degrees, it is very helpful to the patient. And again, when the camera is placed, it should be such that the camera is bisecting the angle between the two working trocars. So the surgeon has two hands, there are two working trocars, and the camera port which is held by the assistant should ideally bisect this angle. So this should be 30 to 30 degrees. And then another thing is called the elevation angle. So whenever surgeon is operating, the angle which the instrument makes with the horizontal axis, this is known as elevation angle. This is not an independent angle rather than it depends upon the manipulation angle. If the manipulation angle is 60 degree, the elevation angle should also be around 60 degrees. But if surgery is such that a surgeon needs to put minor manipulation angles, he needs to operate at 30 degree, the elevation angle should also be 30 degrees. Now, here is another concept which is explained with the help of diaphragm. This is known as fulcrum effect. So, ideally, around half part of the instrument should stay in the abdominal cavity and half part should stay outside the abdominal cavity, so that when a surgeon moves the outer part of the instrument, for example, for X number of distance, the end of the instrument should also move for a X number of instrument. This should be there in 1:1 ratio, the fulcrum effect. Now, the other factors are known as instrument factors. Now, for instruments, let us start with the cameras. Better quality and high definition cameras, they have come, and we have now 3D vision and all that. They cannot completely eliminate the problem of depth perception, but yes, they have compensated for it. Now, also, as we see, the camera angles of our mobile viewing devices and other things have changed. Similarly, the viewing ratio in the panels that we used to have in our laparoscopic suits have also changed. From the ratio of 4:3, the squarish ratio, we have adapted the ratio of 16:9. So what it helps is, it's more physiological, and also there is some amount of peripheral vision in that panel, so that we can see how the instruments are coming and we can see whatever is happening around the surgical site. Also, it was debated and a consensus has been reached that what should be the magnification of the camera. So it has been consensus upon that it should be around 10 to 15 times magnified, the view that we are seeing on the panel, and the panel should be at a distance of 4 to 8 feet from the surgeon's eyes. The next thing is very important, that is how the instrument is made so that it is more easier for the surgeon. And the most important part of the instrument that plays the most important factor in ergonomics is the handle of the instrument. A concept called Mattern Valor handles have come upon, and we can see that the doors that we are having smooth wave-like handles. These handles are made so much so that they fit into our hands very comfortably. This is the relaxed position of our hand, and we should be able to hold these handles in our relaxed position. The same concept has come in ergonomics handles of these laparoscopic instruments. We can see into the second part of the diagram that various handles are there. Some is known as shank handle, pistol handle, axial handle and rod handle. Out of all these, the pistol handle is based upon this Mattern Valor concept, and it feels as if the laparoscopic instrument is an extension of the forearm of the surgeon. It's more ergonomic. Now, we should also talk about what the newer techniques have come upon. The most important technique that has come upon is called as LESS. This is laparoscopic single site surgery. It is also known as SILS, single incision laparoscopic surgery. So the whole concept is, rather than placing multiple small skin incisions, we can place a little bigger single incision, and through that a gel single port is placed. In that port only, there are 3 to 4 spaces where we can put multiple instruments. It feels very good for the patient because there is only a single incision, but the problem is all the instruments are entering the abdominal cavity through a single port. So what the problem is, not only the movements are counterintuitive. Counterintuitive means that we are moving our hand this side, the laparoscopic instrument is moving that side. That was the concept in most of the laparoscopic surgeries, but in these surgeries the movements are counterintuitive. That means that we are moving hand this side, the laparoscopic instrument is moving hand this side, and we need to dissect the other side. So for the surgeon, it is mentally very stressful. Also, it has been seen with the help of the instrument that I discussed before to measure the ergonomics, that it is more stressful for the trapezius and the arm muscles and the forearm muscles. But it has been seen that it is helpful for the wrist aspect. So in entirety, the new single site incision surgeries that have come up, they are more mentally and physically taxing for the surgeon. The second thing that has come upon is called as robotic surgeries, and I hope most of you must be hearing that about in the newspapers. The thing is, in the first diagram that we can see, we are comparing the robotic arm with a human arm. The fact is that we discussed before is that the laparoscopic instrument used to have only 4 degrees of freedom, whereas the human whole arm has 36 degrees of freedom. The robotic arm has 7 degrees of freedom, but that is a considerable improvement than before laparoscopic instrument that we used to have. So it feels like a wrist. The movements are much better. The second important fact that I have shown into the second image is that the surgeon is seated comfortably into the panel. So probably this might be the reason that long periods in a sitting positions are more comfortable, and hence the mental scores in the subjective questionnaires that we discussed above have given better results for robotic surgeries, and also overall robotic surgeries are ergonomically better. So summarizing all the content that we have discussed up till now, I would like to summarize the whole topic in 5 main points. The first is that laparoscopy is a significant departure from open surgeries with all its panels and different way of operating. The second is that optimal ergonomics allows and prevents both the physical and mental wear and tear of the surgeon, allowing optimal performance of the surgery and helping the patient. The third is that correct ergonomics as of now can be objectively studied and subjectively verified. We now have consensus in various fields of laparoscopic surgeries like instrument angles, their lengths, handles, surgeon patient distance, surgeon to panel distance, magnifications and whatnot. The fourth point is that the newer techniques like robotic surgery that are coming are ergonomically better. And the fifth and the last point is that our current aim remains that we are able to communicate better these ergonomics, and we are able to imply these ergonomics in the laparoscopic suite for the benefit of both the patient and the surgeon. Thank you.